Picture this. A healthy young guy develops fulminant meningoencephalitis just days after swimming in a warm, freshwater lake. His cerebrospinal fluid shows highly elevated neutrophils and low glucose. But, and here's the kicker, the gram stain is completely negative for bacteria. What's the diagnosis? And more importantly, what is the single drug combination that might actually save his life? Okay, let's dive into this. Welcome to this explainer on Amebiasis and free-living amoebae. If you're prepping for your medical boards, or honestly, if you're a clinician wanting a razor-sharp refresher, you already know these organisms are absolute examiner favorites. We are doing a rapid-fire, trap-based clinical review today. I'm going to walk you through the highest yield distinctions, the fatal diagnostic errors, and exactly the details they want you to know to secure those points. Here's a quick look at our roadmap. We'll cover the Amebiasis threat, differentiate intestinal from hepatic disease, lock in those strict treatment rules, look at free-living brain invaders, and then we'll finish up with a rapid-fire session of high-yield exam traps. Let's get to it. Section 1, the Amebiasis threat. Let's talk about Entamoeba histolytica. So this organism is a major global player. It's actually the second most common cause of death from a parasitic infection worldwide, right behind malaria. But here is the massive contrast. Despite being such a deadly killer, a staggering 90% of infections present as entirely asymptomatic cyst carriage. That is the setup, right there. You have this massive pool of silent carriers, spreading chlorine-resistant cysts out into the environment, cysts that can survive for weeks. Only 10% of those infected actually develop the severe, invasive, and potentially fatal disease. Now, what's really interesting here is the ultimate microscopic trap. You see, most of those asymptomatic carriers are actually harboring Entamoeba dispar, which is entirely non-invasive. But notice how E. histolytica and E. dispar are morphologically identical? You literally cannot tell them apart on a standard wet mount. The only way, the absolutely only way you can definitively diagnose E. histolytica under the microscope is if you spot hemophagous trophozoids. Basically, trophozoids that have visibly ingested red blood cells. If you don't see those ingested RBCs, you need an antigen test or PCR. Do not fall for this microscopy trap. All right, moving to Section 2, intestinal versus hepatic disease presentations. Examiners absolutely love testing your ability to differentiate these clinical presentations. In the gut, you get amoebic colitis, or dysentery. The absolute histological hallmark you're looking for is the flask-shaped ulcer. It features submucosal extension spreading out under viable-appearing mucosa. But here is the major differentiator from bacterial dysentery. There is a notable paucity of neutrophils on the biopsy and in the stool. Why? Well, because the amoeba's extracellular proteases literally lyse the neutrophils. They destroy them. So if you have heme-positive stools with very few white blood cells, you need to be thinking amebiasis. Now, what happens when it hits the liver? You need to know these amoebic liver abscess buzzwords cold. Men, 30 to 60 years old, single abscess, overwhelmingly in the right lobe. Anchovy paste contents, that's the bacteriologically sterile granular debris you'll see if they aspirate it. And the absolute goldmine buzzword, jaundice is rare. Hepatocellular function is remarkably preserved. So if they give you a guy with right upper quadrant pain, a right lobe cyst, and no jaundice, boom, punch the ticket for an amoebic liver abscess.
Section 3, treatment rules and strict protocols.
Listen closely, because if you break these rules on exam day, or worse, in the clinic, you will lose points and harm patients. So, the crucial point is the combination rule. Step 1 is your tissue amebicide, like metronidazole, to kill the invasive trophozoids actively destroying the gut wall or the liver. But, and this is a big but, metronidazole alone does not eradicate intraluminal cysts. You must follow it with Step 2, a luminal agent like promomycin or iodoquinol. If you just give metronidazole, the patient's going to relapse and continue spreading the infection. Always pick the combo sequence. And pay very, very close attention to this warning. You must exclude Amebiasis before starting steroids. Imagine a patient comes in with bloody diarrhea. You suspect inflammatory bowel disease and blindly hit them with high-dose glucocorticoids. Well, if that patient actually has an E. histolytica infection, those steroids are going to cause a massive, explosive worsening of the colitis. You will trigger toxic megacolon. It is an absolute catastrophe. Keep that in mind. Okay, so that covers the GI tract and the liver. But what happens when a completely different type of amoeba bypasses the gastrointestinal tract entirely? What if instead of being ingested, it enters through the olfactory route, traveling straight up into the brain?
That brings us to Section 4, Free-Living Amebae, the Brain Invaders. These are terrifying and highly, highly testable organisms. Let's contrast the big three you need to know: Naegleria fowleri, Acanthamoeba, and Balamuthia. And this brilliantly illustrates how perfectly they differ. Naegleria hits healthy young people swimming in warm, fresh water, traveling up the olfactory neuroepithelium to cause fulminant primary amoebic meningoencephalitis. Acanthamoeba, on the other hand, causes sight-threatening keratitis in immunocompetent contact lens wearers, but indolent granulomatous encephalitis, or GAE, in immunocompromised patients. And Balamuthia? While that's found in soil, can cause subacute GAE in both healthy and immunocompromised hosts and is uniquely associated with transmission via solid organ transplants.
Let's talk about the sheer severity of Naegleria fowleri for a second. Primary amoebic meningoencephalitis is fulminant and rapidly fatal, usually within just a week. There are fewer than 10 survivors worldwide. Let that sink in. It mimics bacterial meningitis clinically, high neutrophils, low glucose, but the gram stain will be entirely blank, and you will see motile trophozoites directly on the wet mount. Because it is so uniquely lethal, there is a universal emergency protocol. You need a miltefosine-based combination therapy paired with drugs like amphotericin B and fluconazole. You absolutely must contact the CDC immediately. It's almost universally fatal despite treatment, but here is the highest yield pharmacology fact you need to memorize. All 7 known survivors of Naegleria received miltefosine. If you see it as an answer choice for a brain-eating amoeba, take it. No hesitation.
All right, we are in the home stretch. Section 5, High-Yield Exam Traps. Let's consolidate these warnings.
Let's rapid-fire these traps so you can recall them instantly on exam day. Ready? 1. E-histolytic cysts are chlorine-resistant. Disinfecting water with standard chlorine just won't work. You have to use iodine. 2. Amic colitis presents with significantly less fever than bacterial dysentery. In fact, fewer than 40% of patients are even febrile. 3. While most liver abscesses are right-sided, if they present with a left lobe abscess, watch out. That leads to pericardial rupture, which carries the absolute worst prognosis. And 4, serology can actually be negative in the early stages of a liver abscess, up to 10% of the time. Don't let a negative early ELISA fool you into ruling it out prematurely. Let's move 2 and see how this spills into our ultimate takeaway, the one fact you absolutely must burn into your memory. Microscopy cannot distinguish E. histolytica from E. dispar unless hematophagous trophozoites are seen. It is the single most common trap examiners use to trip you up. Without seeing those ingested red blood cells, you're looking at morphologically identical organisms, and you must demand an antigen test or PCR. So I leave you with this. In the high-pressure environment of modern medicine, and honestly, on exam day, will you recognize the fatal diagnostic trap before it's too late? Stay sharp, keep these high-yield facts in focus, and you're going to nail these questions every single time. Thanks for joining me on this explainer, and keep crushing your review.